Assalamu alaikum. My topic is rapid sequence induction in intubation. I will start with the overview, which is the introduction, differences between the conventional and rapid sequence induction in intubation, and the indication for rapid sequence. And the most important is rapid sequence induction in intubation in the COVID-19 patient. And lastly is a method. So introduction. So rapid sequence induction in intubation, or we can say is a rapid airway control, is a technique to achieve adequate depth of anesthesia in most often paralysis for laryngoscopy and intubation. The goal of rapid sequence induction in intubation is to prevent the coughing, bucking, straining, and regurgitation during the airway manipulation, such as endotracheal intubation. Differences between the conventional and rapid sequence induction in intubation is conventionally we start with the administration of induction agent, then we wait to see the proof of ability to mask ventilate, then we are administering the neuromuscular blocking agent. Once we ensure, then we start the endotracheal intubation, and usually conventional intubation takes 3 to 5 minutes interval between the induction and intubation. The rapid sequence induction and intubation is a more smooth, quicker, and patient become unconscious and muscle relaxation usually can be done in the 1 minute between the difference between induction and intubation without the using bag mask ventilation. The indication for rapid sequence induction and intubation is the patient with the full stomach, such as emergency surgeries, or patient having a trauma, incomplete NPO, or other is the gastrointestinal pathology such as a small bowel obstruction or gastric outlet obstruction. Patient is a known gastric reflux disorder. Lastly is the patient with the increased intra-abdominal pressure such as morbid obesity, pregnancy, ascites, and airway anomalies such as a facial-maxillary malignancy which causing reducing the mouth opening. So the important is rapid sequence induction and intubation in COVID-19 patient. The novel coronavirus is a high risk for aerosol spread of virus during laryngoscopy and intubation and other airway manipulations. So the rapid sequence induction is facilitating by securing a rapid airway control without vague mask ventilation, means preventing the aerosol generated induced contagious virus infection to the provider, and which also helps in first attempt success in keeping the patient and operator safe. So with the start with the roles are rules. The minimum airway team comprised of 3 members such as an intubator, assistant, and drug administrator. In case of a failed intubation, another intubator must be ready outside the COVID room in case we can call him for help. Okay, the checklist for rapid sequence. So we have a number of P's like a preparation, the drug, equipment, people in the place. We need to assess the cervical spine, positioning the patient such as a head up, bed up, or using the ramp. Pre-medication, pre-oxygenation, pre-treatment, paralysis and induction, pressure on cricoid cartilage, placement and proof, and other is the post-intubation management. We have a number of induction agent and that can be used depending on patient to patient. Like if you have a stable hemodynamically patient, you can use a propofol 1.5 to 2 milligram per kg. Usually its onset is 15 to 45 seconds. There are other agents like a ketamine and etomine that can be used in unstable hemodynamically patient. And we have a fentanyl, midazolam, and ketamine. They are usually used as a crush induction, while conjunction with the ketamine and the midazolam or ketamine with the fentanyl can be used as an induction agent. And now as a paralytic agent, we have a number of paralytic agents such as a succinylcholine is 1 to 2 milligram per kg is an ideal agent which gives you smooth relaxation in early onset. We have a rocuronium, vicuronium, and the cis-itracurium. Pre-treatment in some patient, laryngoscopy cause a bradycardia like in pediatric patient. You can give atropine 20 mics per kg before laryngoscopy. And in some patient like ischemic heart disease, raised intraocular pressure, there's a chance for hypertension, tachycardia, and laryngoscopic induced. So you can blunt that response with the lignocaine 1.5 milligram per kg, or the fentanyl can be used 2 to 3 max per kg. If in case you have decided for using a succinylcholine and patient is complaining of the muscle pain, that easily you can defasciculate with the dose of non-depolarizing muscle relaxant has to be given 20 seconds before at the dose of 0.01 milligram per kg rocuronium or vocuronium is the 0.01 milligram. Usually it prevents or defasciculate. Modified rapid sequence induction agent. Actually, there is no standard definition. Modified means either to addition of the mask ventilation that usually is not bag mask ventilation is recommended. And other is the use of a cricoid pressure. The common scenario in which the modified rapid sequence induction is followed like a difficult airway and high risk for respiration, that we usually use a cricoid pressure, or the bag mask ventilation, like a patient with poor oxygen reserves are prone to desaturate. But note, try to avoid bag mask ventilation in COVID-19 patient to prevent the aerosol generating infection. And the troubleshooter, if in case you fail to intubate or you have a difficulty, you should available and change of a hand, bed position, plate position, and you can, if your patient is developing hypoxia, you can wait to rebuild the oxygen level by the low tidal ventilation. If the patient is developing hypotension, you can give a vasopressors. If in case patient developing regurgitation and aspiration, you have to suction and the bed reposition and avoid the aspiration. Contraindication, yes. Rapid sequence induction, if you have a poor functioning team, hostile environment, lack of requisite skills, and if in case the threatening airway is very difficult to pass the endotracheal tube and you have not available emergency surgical airway team. Now final is the summary, the use of a rapid sequence induction agent or the conduct in COVID-19 patient. So always review airway plan as a team before entering the patient room. Prepare all equipment such as an endotracheal tube, suction, bougie, syringe, different type of endotracheal tube. Draw and label the medications, induction agent, neuromuscular agent. If it's possible to intubate the patient in negative pressure room. And the bag mask ventilation if it's unavoidable, and use the HEPA filter. Always use video laryngoscope which give you clear view and the first success chance, and also is minimum 1 to 2 feet prevent the operator from the patient mouth, which prevent the aerosol generating contagious, and others the waveform capnography. Pre-oxygenation is the important step in rapid sequence induction. Actually, for 3 to 5 minutes with 100% oxygen, and always use a low flow as a 10 to 10 liters is fine in the COVID patient. What we do in pre-oxygenation, actually we denitrogenating, increasing the oxygen level in the lungs, which indirectly giving us a more apnea time if in case we need a more time to secure the airway. Always avoid a high flow oxygen and always avoid a nasal cannula, and make sure the patient having a reverse Trendelenburg or head up position to prevent the hypoxia. So the intubation steps. So the pre-treatment that we discussed, the choice of muscle relaxant and the induction agent depend on the patient to patient. Cricoid cartilage has to be attained to 30 Newton pressure. Video laryngoscope, endotracheal tube has to be fixed at 90 to 22 centimeters. Inflate the endotracheal tube immediately, and then to confirm the endotracheal tube by the colorimeter, or you can auscultate, but try to minimum disconnection. When you disconnect, you use a smooth clamp in the endotracheal tube, and once you confirm and you directly attach with the ventilator, and then the HEPA filter is to be fixed with endotracheal tube and ventilator, and then you start the mechanical ventilation and secure the endotracheal tube. Thank you very much.